Welcome guys to the Finals Crash Course series. So today's session is ENT, taught by Dr. Jess Caterton. So in the top right corner, you can see the QR code for our Instagram page, and in the bottom left corner is our email if you have any questions. So please do email us. And this video will be uploaded on YouTube as well. Go on to the next slide. So this is the QR code for the polls. So please do scan, and it's completely anonymous, so give it a go when we're going through the SBAs. And I'll post the QR code in the chat as well as I'm going along if people join.
So who I am, my name is Jess. I studied at Oxford. I'm currently doing an F3 where I'm taking a year out to do a master's, but I have already got my MRCS and I'm looking to be a surgeon in the future, hopefully. So hopefully I've got something useful to say about ENT for you today. I should do. So the topics covered in this talk are shown here. This is not an exhaustive list, so please make sure that you check your own syllabuses to make sure you revise everything that may come up in your finals, but this is what we will go over today. And a disclaimer, as I said, the contents of these slides are not comprehensive. Please make sure you look at your own syllabuses to adequately prepare for your finals. Finals also vary sometimes from course to course, so make sure you're aware of any local guidelines. I've written the short single best answer questions, so please don't copy them or use them. I have no conflicts of interest, and the resources that I used when I studied and that I recommend are Oxford Clinical Handbook, or the Cheese and Onion, Teach Me Surgery is great, and PassMed. So we'll start with the first SBA. A 25-year-old woman presents with a history of gradual progressive hearing loss. She describes it as affecting sounds of all pitches. She reports her father had a similar issue and is now deaf. Audiometry reveals a bilateral mild to moderate conductive hearing loss. What is the most likely diagnosis? Okay, so the answer is otosclerosis. The genetic component, her age, the gradual hearing loss, and the fact it starts as a bilateral mild to moderate conductive hearing loss is in keeping with otosclerosis. Second question, a 57-year-old man presents with a sudden onset left-sided hearing loss. He reports having a flu-like illness 3 to 4 weeks ago, but is otherwise fit and well and takes no regular medications. Weaver's test lateralizes to the right and Rennie's test is positive bilaterally. What is the most likely diagnosis? So the answer is acoustic neuroma. So this is an older person. Yes, they've had a flu, but 3 to 4 weeks ago, not really in keeping with, well, any of these anyway. Sudden onset, no other symptoms, and this description here is of a sensory neural hearing loss, so that is in keeping with acoustic neuroma. So the approach to hearing loss. So this hearing loss can be split into two, into conductive and sensory neural. Conductive, these are your differentials, and then sensory neural, you've either got bilateral, so both sides, or asymmetrical. Acoustic neuroma is the one really that's a red flag. So unilateral sensory neural hearing loss is a red flag symptom and needs to be investigated. Weaver's and Rennie's tests help you to determine whether something is conductive or sensory neural. So Weaver's test basically tests conduction, and if one side you can hear better than the other side, then that implies that there's a conductive element to your hearing loss. Rennie's test, on the other hand, sees if you have sensory neural, and what you should get is that you can hear better with air conduction, and depending on the side it affects relative to the Weaver's test. That's how you get that's how you can figure out whether it's sensory, neural, or conductive. These are audiograms, and they basically show another way that we can figure out what type of hearing loss an individual has and at what frequencies, just to point out some of them. So this is presbyocusis, which is in age-related hearing loss. Basically, you lose higher frequency hearing completely before lower frequency, and it progresses over time. Noise-induced, you get a loss at 4 kilohertz, and it's often after a very large noise. And then otosclerosis here is this mild to moderate conductive hearing loss that's bilateral. Okay, next SBA. A 32-year-old woman presents with a new onset hoarse voice. She had a total thyroidectomy 6 months ago for medullary carcinoma. Calcitonin levels from 1 week ago are undetected. Examination of the neck, including the lymph nodes, is unremarkable except for a healing thyroidectomy scar. What is the most likely cause of her hoarse voice? Cause of her hoarse voice. Okay, this one's recurrent laryngeal nerve palsy. Thyroidectomies, you risk damaging this nerve. It's not likely to be a recurrence because the calcitonin levels are not high. Deep lymphadenopathy is not really a thing. Laryngeal carcinoma would be pretty unfortunate in a 32-year-old. And SLN palsy, less likely. RLN is more likely. A 72-year-old man has recently been diagnosed with a laryngeal carcinoma. He had a resection of the tumour and has returned to the clinic to discuss the histological findings. What is the most likely histology finding given his diagnosis? So the answer is squamous cell carcinoma. Head and neck cancers are most likely to be a squamous cell carcinoma. A 47-year-old Asian male has recently been diagnosed with a nasopharyngeal carcinoma. He asks to speak to you on the ward. He explains he was told his cancer may have been caused by a virus, but couldn't remember which virus it was. Infection with which virus is most associated with this condition? So it's Epstein-Barr virus. So, patient with a hoarse voice. Look for red flags. Most important thing, look for red flags. And these are some other red flags that you might consider, including things like referred ear pain or like mouth pain, stridor, difficulty swallowing, smoking. Once you've covered the red flags, you then need to think about examination. So essentially you want to look at all the systems in the head and neck area, of which there are a lot. So you've got respiratory, oral and oropharyngeal, cranial nerve, neurological. You want to palpate the neck for lymphadenopathy and thyroid masses. And you might want to do some investigations like FNE or other simple imaging techniques. So this slide is designed for you to pause and have a look at it. This is just a differential diagnosis for hoarse voice, but you can generally split it into benign, infective, neurological, malignant, and then some functional ones. Okay, next question. A patient presents to A&E with a 40-minute history of a nosebleed that won't stop spontaneously. The patient is hemodynamically stable and their VBG hemoglobin is 120. The A&E SHO has trialled anterior nasal packaging, but without success. She was unable to identify a culprit vessel on examination, but did report seeing blood in the oropharynx. What would be the next best step in the management of this patient to stop the bleeding? So the answer here is posterior packing, such as with a Foley catheter. So the patient proceeds to have a Foley catheter inserted. However, despite working for a brief period of time, the bleeding continues. The patient is reviewed by the ENT registrar, who decides that the patient is going to need surgical ligation to manage the bleed. Which artery is most likely to be ligated? So the sphenopalatine artery. And I'll show you a diagram shortly. Here is the diagram. So epistaxis, 90% are anterior, whereas 10% are posterior. So this one would have been quite a rare bleed. The reason the 90% occur anteriorly is because you've got this area here called Little's area, which is essentially an anastomosis of all of these blood vessels that supply the nose for its various functions. So this is the most likely area to be implicated. However, if you have a posterior bleed, lots of these arteries can be the cause, but the most likely is this one here, which is the sphenopalatine artery. And you can imagine if there's a bleed here, it would drip back into the oropharynx. So most cases are due to trauma, including nose picking or a foreign body, so make sure you ask. But other important causes and things that you need to think about when people come in with nosebleeds, especially major nosebleeds, are shown here. So things like clotting problems, malignancy, or high blood pressure. Investigation and management wise, look for any of these trauma issues, drug history, including recreational, if they've had previous episodes, and then any other signs, symptoms that might indicate sort of a deeper underlying problem. And then with management, it really depends on the size of the bleed. Keep someone sat up and sat forward, protecting their airway. Really, really important you do an ABCD approach, especially with large bleeds. You might think, oh, it's just a nosebleed, even if it's heavy. But nosebleeds actually can kill. And I've seen it, or I've seen very close to it, and I've heard of it. So, I would highly recommend, if someone's had a large bleed, have an index of suspicion that they might have lost a large amount of blood, make sure you do an ABCD approach, make sure you get bloods including hemoglobin to know how much blood they've lost, and try and get on top of the bleed as soon as possible. Simple things you do at the start: nose peg and an ice, and then you want to have a look. Ideally, if you can't see anything, adrenaline soaked gauze is a good way of causing vasoconstriction in the nose so that you can see better. And if you can't identify bleeding, have a look, generally always have a look in the back of the mouth, because if you see dripping of blood down the back of the mouth, that could imply there's a posterior bleed. So the epistaxis ladder is how we manage nosebleeds. So firstly, if you can see a vessel that's anterior and you are trained in cautery using silver nitrate, then that is the approach you should take. Otherwise, it's basically packing. You start anterior. If that doesn't work, you try posterior. If that doesn't work, you might need to do a surgical intervention, such as ligation or radiological embolization, and that would be the ENT that would be doing that. Okay. You're asked to see a 3-year-old boy in Peds A&E. He's presented with a fever and rapidly worsening sore throat with no cough. The paediatric triage nurse is concerned, as the boy is now making a hoarse sound on inspiration. On examination, you note the boy is drooling and appears in distress. His father, who is present, says they recently moved from a refugee camp where the boy was born. What is the most important first step in this patient's management? Okay, so the answer is urgently call anaesthetics or ENT, as this patient's area is potentially compromised. This sounds like epiglottitis, and so you need to get a senior person with an area on board. But most of the other things here you should also do, the exception being examination of a patient's oral cavity or airway, because this can trigger laryngospasm and take away an airway that might still be there, and obviously that's a serious emergency. So Stridor, you can get acute or chronic stridor. Red flag, stridor is kind of a red flag by itself, but there's other things that you want to be extra worried about if there is stridor, such as if the sound is actually decreasing, it might imply that airway is shutting off. And then a list of these things below, which are kind of indicative of some of the acute causes of stridor, which we're more worried about. So acute management, you need to stabilise the patient, give them oxygen, and make sure you've got suitable specialists around. You can try and suction or remove a foreign body, but please make sure you can see it and that you're trained and that you do not irritate the airway, especially in kids. Adrenaline, steroids as necessary. Take bloods, ABG cultures, and probably do a sepsis 6. An emergency situation, if you don't have an airway, there's things like cricothyroidotomies or intubations. Investigations, you're going to probably do the basic stuff first in most situations, and then you kind of will narrow it down afterwards. But if it's a non-emergency or chronic, you might do things like visualization of the upper airway and CTs. Just be careful with any airway examination, especially around epiglottitis croup and in young kids. You do not want to irritate the larynx, cause laryngospasm, and cut off their airway. So these are the 2 infections that you might want to worry about. Epiglottitis, often caused by H. influenzae, and so most people get vaccinated when they're children, however they might not, and so it's really important to get a vaccination history, because that might lead you towards being more suspicious of this. And it essentially gets treated with adrenaline, dex, and antibiotics. Croup is a lot less serious, but you might still want to give them dex, and you might still consider there's some reasons to admit them. Okay, next SVA. An 18-month-old presents to the GP with a parent with a 24-hour history of agitation, low-grade fever of 37.8 and tugging at her right ear. Her mother says she has had a cold for the last few days, which she thinks she caught from nursery. On examination, she is not septic. However, her right tympanic membrane is inflamed. What is the most appropriate management of this patient? Okay, so this is give a delayed prescription of antibiotics if the patient doesn't improve in 48 hours. A 24-year-old triathlete presents to the GP with symptoms of a persistent discharge from their left ear. She also reports some fullness in the ear and tinnitus on examination. On examination, her external auditory canal is inflamed and there's yellowish discharge. Her tympanic membrane appears normal. What is the most likely diagnosis? Otitis externa. Okay, ear pain and discharge. So, firstly, the pain might not actually be coming from the ear. So, if it's referred ear pain, so everything is normal in the ear, you need to think, is it being referred from somewhere else? Things to consider are shown here. So, all these nerves kind of supply areas of the ear and cause referred pain. The biggies, malignancy. So, yeah, it's definitely something you need to consider. If the pain and discharge is coming from the ear, one of the key diagnoses is acute otitis media. This is basically an ear infection, or you'd colloquially call an ear infection. It can be caused by bacteria or also viruses. Often happens in kids. They generally are kind of run down, coryzal, and so on. The tympanic membrane is swollen, it bulges, it may be perforated during a discharge, and most resolve on their own. However, if it lasts more than 72 hours or going into day 4, that would be a reason to give antibiotics, or if someone is systemically unwell or is vulnerable. Admit them if they've got, they're very young with certain high temperatures. This should be 39 and not 30. Let's even let me do it. Yeah, 39. If they're septic, if they're children with cochlear implants or their complications. Complications include mastoiditis. This is when the infection spreads to the mastoid cells. The mastoid is behind the ear, posterior to the ear. And what you notice is a boggy erythematous swelling behind the ear, and it can also push the pinna forward. These need IV antibiotics, and if there's no improvement, they need a CT head after 24 hours, and you might have to even do a mastoidectomy to drain the site if the IV antibiotics are not effective, and what you're worried about is it spreading to the brain. Other things to be aware of are meningitis, facial nerve paresis, sigmoid sinus fibrosis, chronic otitis media, and this abscess. Okay, chronic otitis media is when the discharging lasts more than 6 weeks. Usually you treat it basically with antibiotics, steroids, and washing out of the ear. However, you need to think, is it a cholesteatoma? And this is the most important thing to pick out in this. So this is when you have a pocket of growth in the attic of the middle ear. So when you examine an ear, you should always look up, like you look in the ear, but you need to make sure you see the top of it, the roof or the attic of the ear, because that's where the cholesteatomas are. They're not really metastatic, but they're locally invasive, and obviously you've got lots of important structures just behind the ear, including lots of cranial nerves and the brain, and so it's important that they get removed. So generally, if they do have them, you do a CT to see the extent, and then surgically remove them with the aim of stopping them spreading any further. Otitis media with effusion is more like a chronic inflammatory changes within the middle ear. Often presents with kids who aren't paying attention at school, or their speech and language development is not doing as well as the rest of their development. They have a dull tympanic membrane with a loss of the light reflex. Some of them resolve within 3 months without any help, but others might need hearing aids or grommet insertion and worst case adenoidectomy. Otitis externa is the outer part of the ear that's affected, so the external ear. These are the common pathogens that get affected, that cause it. Risk factors, so people who have lots of water contact like swimmers or human environments, if you have ear eczema, psoriasis, or if you have local trauma, including using Q-tips, essentially get painful, itchy, purulent ears, often with some fullness, and sometimes you can get some more significant symptoms. Generally prevention, so don't use Q-tips when you swim, try and dry your ears, and so on and so forth. However, other things like oral, toileting, antibiotics, analgesia, microsuction help. It's really important to look out for malignant otitis externa, and it's quite a popular exam question. So if they're elderly, diabetic, immunocompromised, you need to be thinking urgent CT, and they might need IV antibiotics. Other complications include mastoiditis, osteomyelitis, and intracranial spread. Okay. A 62-year-old man presents to the GP with, presents to A&E with symptoms of vertigo. He describes them as coming on all of a sudden and lasting seconds to minutes. He notices they occur with specific movements, for example, when turning over at night to speak to his partner. Which manoeuvre is used to help diagnose the condition this man is describing? So this is the Dix-Hallpike manoeuvre. So BPPV, which is what this patient was describing, caused by basically stones in the canals in the cochlea. And so fluid normally flows in these cochlea, in these canals, and the stones block the fluid moving. So when you move, the fluid doesn't move with you, and then you get a discrepancy of signals basically to the brain, which creates a symptom of vertigo. To investigate it, you do the Dix-Hallpike manoeuvre and you see nystagmus. And to treat it, you do the Epley manoeuvre, which essentially is like shifting these stones, getting them out of position quite cleverly. And sometimes people need repeat ones to do it. Vestibular neuronitis is another cause of vertigo. Typically happens after an upper respiratory tract infection. And basically you get really bad vertigo, often nausea and vomiting as well, but otherwise everything's unremarkable. Essentially it's a bit of a time will make it better situation, but you can also use vestibular sedatives. You might need to give fluids if they're so dehydration from vomiting, and some people need longer term rehab if they get significantly affected by it. Meniere's disease, so this is an idiopathic disorder, comes with a triad of severe paroxysmal vertigo, sensory neural hearing loss, and tinnitus. Symptoms are usually unilateral, and they can last minutes to hours, but they usually resolve in less than a day. And repeated attacks can actually cause sensory neural hearing loss. Everything kind of looks normal investigations, but you might see some changes in the audiogram depending on how long they've had it. To manage it, so in the acute attacks, things like prochlorperazine are helpful, and then prophylaxis is the really important thing. So advice such as reduce salt or avoid chocolate and caffeine are important, and then beta histine medication. And occasionally you can do surgical things, but that's generally the very last line. Okay, a 54-year-old male presents with persistent discharge from his left nostril. He describes the discharging for 3 weeks, not associated with any fever, but he does have a chronic cough. The discharge is yellow and occasionally has some red stained streaks. He also describes some fullness of his left cheek, but has no pain or other symptoms of note. He has a past medical history of hypertension and type 2 diabetes, and recently quit smoking after being diagnosed with COPD. What is the next best step in this patient's management? So urgent 2-week wait ENT referral would be the right answer. This person has got unilateral discharge with blood streaks, got smoking history, 54. You want to worry about cancer. Okay, so red flags for nasal discharge. So unilateral nasal discharge is a red flag, and other things are basically surrounding infection or like an idea of a growing mass, which may imply a malignancy in the head and neck area. However, something that is less of a red flag is rhinosinusitis, but it's another reason why you might get chronic nasal discharge. So it's when you get an inflammation of the lining of the nasal mucosas and sinuses, often caused by a number of different bacteria. And things like if you have nasal polyps, a deviated septum or dental infection can cause or predispose it. You can get severe facial pain worse than bedding down with this. Things you might do: have a look in the nose, CT scan, and things you try and do are decongestants, anti-inflammatories, and antibiotics. Can cause complications listed here, and in these situations you want to escalate to IV antibiotics, CT, make sure you get the appropriate people to have a look, and you may need surgical intervention. A 27-year-old male presents with a slow growing mass of the parotid. There's not facial nerve involvement, and CT neck and thorax showed no lymphadenopathy. Following resection of his parotid gland, he has returned to discuss the results. The histology report describes proliferation of epithelial and myoepithelial cells of the ducts and an increase in stromal components. What is the diagnosis? So, benign pleomorphic adenoma. A 65-year-old lifelong smoker presents to the GP following a routine dental appointment, where it's noted he had some white patches in his oral cavity. He describes feeling well in himself and has no other symptoms of note. On examination, you note multiple small white patches in the oral mucosa. There's no associated cervical lymphadenopathy, and other than noting his poor dentition, your examination is otherwise unremarkable. What is the most appropriate next step for this patient? So urgent 2-week wait, ENT referral. Okay, head and neck cancers. So we'll start with salivary gland tumours. So parotid here, which is what the first SBA was referring to, you can see most of them are benign, 80%, remember that number, and 20 are malignant. Submandibular and subclinical, however, are more likely to be malignant rather than benign. Risk factors, EBV, smoking, and then radiation, genetic alterations. What they find is a slowly enlarging mass. You might have a facial nerve palsy that probably implies a more invasive feature. You can get things like airway obstruction, of course, lymphadenopathy. Investigations are routine, but you want to try and do an FNA, and you consider CT neck and thorax if they're malignant. And management is surgical excision and radiotherapy, either as an adjuvant or if the tumour is not probable on its own. So parotid tumours, look at this in your own time, but I just want to draw your attention to benign pleomorphic adenoma, which was the answer to the SBA, and this 80%. So essentially, things to know about parotid tumours, or key things for finals are 80% are benign, and 80% of those benign tumours are benign pleomorphic adenoma, making this the most common parotid mass. So that question seemed difficult because it was describing sort of complex histology that I got from here. However, in reality, it's more of it's a process of elimination. It's a unilateral mass. It's not invading the facial nerve. No risk factors, probably benign pleomorphic adenoma. Other ones to be aware of are Warfarin tumours. These are generally the most common bilateral benign neoplasm of the parotid. So they are in your differential if you've got benign enlargement of your parotid, and they're associated with smoking. The most common malignant form of parotid tumours is the mucoepidermoid carcinoma. Head and neck cancers. So this is generally referring to malignancies of oral cavity, pharynx, larynx, sinuses, nasal cavity, salivary glands. Quite a few questions have touched on this in this presentation. They generally come from squamous cells, the squamous cell carcinomas, as I mentioned earlier, and they're more common in men, and there seems to be rising incidence of certain cancers, probably because of HPV affecting the younger population, or this might change now that vaccinations are coming in, and now we vaccinate males as well as females for HPV. So risk factors generally are modifiable behaviours, so alcohol and tobacco use account for about 75%. HPV, mostly type 16, but also 18, is also linked with oropharyngeal cancer, and then some more niche things such as Betel liquid, occupational wood dust, and EBV is linked with nasopharyngeal carcinoma, which also generally affects the Asian population. So features, often they're non-specific and unfortunately caught quite late. But things to look out for, and what one of the questions was referring to, was pre-malignant conditions. So this is often really for oral cancer, but you can get white patches, red patches, a mixture of them, and these two other things, oral lichen planus and actinic cheilitis. These may be pre-malignant conditions, and so if patients present with these, keep them in mind because they may warrant a referral and biopsy. Generally, though, you get referred symptoms. Sometimes you find a mass, but the presentations are non-specific, so it's important to look for the red flags and send them for referral if appropriate. So there's a lot of information on this, but I just want to point at referral quickly. So for laryngeal cancer, if they've got unexplained hoarseness or they've got a lump, so including lymphadenopathy, you might want to refer. Oral cancer, if they've got any of these pre-malignant conditions for more, or ulceration for more than 3 weeks, or any lumps that look dodgy and unexplained, you need to refer. Investigations are generally either looking with like FNE or doing FNA or CTs. And management of head and neck cancer varies massively, but I mean the mainstay is surgically remove it and then do chemoradiotherapy, or if you can't remove it, radiotherapy, chemotherapy, and it's a very MDT heavy specialty. There are some complications which may happen following it that you can have a look at here. So that's the end of this presentation. Not completely exhaustive, but hopefully has touched on some key topics in ENT. This QR code should still work for a little while while it's up on YouTube, so if you have any feedback, we massively appreciate it. and thank you very much for listening.